So it's my pleasure to introduce now a unique person, and you can. He's Professor Muhammad Maghni. إذا الأسم بعطيكم إشي. He's from Lebanon, and he's Italian. So let's say he's Italian. He's from Lebanon. He's a professor of pediatrics and a head of the pediatric clinic, and the service in pediatric endocrinology, diabetes and metabolism at the Giannina Gaslini Institute, University of Genoa. He has been participating in many universal ESPE meetings, ESPED, and he was responsible for the Summer School Steering Committee. He has authored more than 200 peer-reviewed papers, and he will enjoy us for the next 20 minutes before the Friday prayer and lunch for talking about the role of neuroimaging in the diagnosis and prognosis of hypopituitarism. Please, تفضل.
Thank you very much, Salam, for the kind words. Assalamu alaikum. This is my first time in Beit Lahamed. It gives me a great pleasure to be here. And I would like to thank the organizing committee and Abdul Salam for the great hospitality. So, what I would like to share with you some new information. This is a quote by Caffey in 1956, where you can see the quote is a little factual basis for a belief that a pituitary fossa is significantly altered in diseases other than those associated with expanding lesions of the pituitary and sometimes of increased intracranial pressure. Of course, the information after 1987, when MRI became available, have completely changed the shape of pituitary information. And what I would like to share with you is some example from clinical practice, and go to the relationship between pituitary morphology, function, etiology, and outcomes, and then some take-home messages. So this is a case one when twin pregnancy from assisted reproductive technology, premature delivery at 26 weeks, adequate intrauterine growth pattern, no hypoglycemia, jaundice, or other symptoms, inguinal hernia, and within the local protocol in the neonatal ICU, MRI was performed at 41st weeks. So you may see this is a condition. This is the pituitary, the sagittal section of the normal pituitary gland, showing the anterior pituitary, the pituitary stalk, and the hyperintensity of the posterior pituitary, suggesting a normal functioning. While this is the index case where the posterior pituitary is ectopic at the level of the eminence, median eminence, and the pituitary stalk is not visible, and you have a shallow sella. So this is a pituitary stalk interruption syndrome, and you can find it in orphan as with this code. So the first question is why this patient has structural pituitary, hypothalamic pituitary abnormalities. And it is a chance occurrence, it is a normal variant, is it idiopathic hypoped, is it a congenital hypoped, is it genetic condition or something different. So this is the pattern of growth, of weight growth of the index case, and this is a twin showing normal growth in terms of weight, and this is indicated by, this is a 25 to 26, 25 to 26 growth chart, showing that the green is similar to the weight growth. So what about the lengths? So here is the index case, and you may see the drop in gross velocity as compared to the other twin, who is still in the normal range. So the second question for clinical practice, what we'd like to do next, is endocrine evaluation, additional workup, genetic analysis, wait and see, or something different. And here you can see the analysis of thyroid function for 45 weeks, showing the FT4 at the low level, while the cortisol level was low as well. IGF-1 was normal, which is not very reliable this time. And the baseline growth hormone was normal. So, second question is what we would like to do next after this evaluation. Is ACTH test, we heard about ACTH testing, start thyroxine treatment or thyroid function follow-up, clinical follow-up, wait and see, or something else. And here you can see after 10 months there was a drop in T4 level under 12, and with an increase in TSH suggesting a central hypo. This is 20 months later, while after 5 months and because of surgery for hernia, the ACTH testing was done, and you may see that the borderline cortisol is between 16 and 22, and the index case has low cortisol level. So, and this is the growth after 15 months, showing that this is suggestive of growth hormone deficiency as well. And the result of glucagon tests show a growth hormone value of more than 10, and with IGF-1 normal. But we do know that growth hormone peak could be higher than 10. This is a paper by our group in the glucagon test published in JCNM, showing that many patients with congenital hypopit may even have growth hormone higher than 10. So the testing, pitfall in the testing could be possible. So this is a second case. This is mother with past history of hyperprolactinemia, treated with cabergoline, bridge presentation and perinatal. He showed perinatal asphyxia, and he was transferred to neonatal ICU. And the same. This is a different picture. We have indeed an ectopic posterior pituitary. We have a biggest anterior pituitary, and we have a visible pituitary stalk. And this guy had isolated growth hormone deficiency. This is the growth pattern showing a deceleration of the growth while the weight and the head circumference were normal. The growth hormone testing showed that it is less than 10, and of course, the diagnosis was growth hormone deficiency. And these two guys are different in terms of prognosis because they have different pictures, being the pituitary stalk visible. And I'll give you some information in my talk. So all these two patients, and we have many patients like these, don't have any symptoms of sign of neonatal hypopit, including hypoglycemia, seizures, or poor feeding, hypertonia, nystagmus, or other sign. Only one patient had bridge presentation, and of course, which is not enough to make any diagnosis. So the summary is that the pixel words is 7 words, MRI with pituitary stalk interruption syndrome in these two cases, early prediction or treatment of endocrine dysfunction could be available, and more information that you can find because the glucagon test show definitely a pitfall in the diagnosis. So the spectrum of congenital hypopit is really incredibly variable, and going from normal MRI to an empty cell to the ectopic posterior pituitary in conditions with isolated growth hormone deficiency or mainly combined pituitary hormone deficiency. And of course, these abnormalities may be even more complex, as you may see in suboptic dysplasia or other conditions. So, does pituitary phenotype matter? First question is, yes, it matters. The relationship between phenotype and genotype in these two guys show that there is no correlation. You may see that this is a child with idiopathic combined pituitary hormone deficiency. This is another genetic condition, PIT1. This has been reported in 92 in Science, showing prolactin deficiency, growth hormone deficiency, TSH deficiency. This is HESX1, has been reported by me in the Thani in 98, showing septooptic dysplasia pattern, and this is GLIS3 mutation in a patient where the phenotypes are quite similar. Unlike the clinical phenotype and the biochemical phenotypes, the MRI phenotype is suggestive. In this guy, we had ectopic posterior pituitary. In this other one, there is normal pituitary region. In this one, we have complete agenesis of the anterior pituitary. And this guy had a big hamartoblastoma, which means that this is a brain malformation and doesn't mean any surgery. So, what are the main neuroimaging features and underlying causes of pituitary findings in congenital hypopit, and how neuroimaging could help in the diagnosis? This is a busy slide showing the multiple players where some genes are involved in the secretion or synthesis of growth hormone. Other genes are involved in the development. So they may have, these patients may have abnormal pituitary gland, and so we need to make a diagnosis, an etiological diagnosis, which is not always easy. So this slide summarizes several genes presenting in several conditions, so presenting different endocrine phenotypes, different pituitary phenotypes, and also associated extra-pituitary and extra-CNS phenotypes. But just to make it simple, there are 4 colors. They are divided into 4 subgroups. The first one being associated with normal pituitary gland and isolated growth hormone deficiency, and less for IGH type 2. This has been published by Primus Montes, who passed away a few years ago. And these patients may develop multiple pituitary hormone deficiency. The light blue is representing some genes associated with normal pituitary stalk development. And the green one may be associated, these conditions, all these genes may be associated with different phenotypes. So it would make the diagnosis very complex, while the pink one is associated with those overlapping genes, including Kalman syndrome and others. So just some examples. These conditions like PROP1 and LHX3 will never have any abnormality of the pituitary stalk, but they could be associated with pituitary mass, as in the PROP1, and this is LHX3. This has been reported in collaboration with the French and German group in Natural Genetics in 2000, and this should call to the attention of physicians, and we need to avoid any unnecessary surgery because this is a self-limited condition. So these are 2 brothers showing PROP1 gene mutation with pituitary mass developing in this 5-year-old guy, and with the youngest brother was less than 4 years, showing a mass, and the diagnosis could be made earlier. So, what about the pituitary stalk interruption syndrome, which is very complex? And you can see that you need to collaborate with your neuroradiologist, and the picture could be extremely variable. This is an ectopic posterior pituitary at the level of the hypothalamus. But this has specific prognosis. This is downward the median eminence, and you may see that ectopic posterior is within the pituitary stalk. It's at the proximal part of the pituitary, or even squeezed, or in the pituitary stalk, as in the patient. We may have even double posterior pituitary, ectopic posterior pituitary. So the phenotype of the pituitary gland is extremely variable. So we have to be careful about the extra pituitary abnormalities, like these patients who may have arachnoid cyst or Arnold-Chiari 1, and many of these abnormalities could be picked up by MRI very easily. But unlike the MRI, every single patient with congenital hypopituitarism should be checked for other abnormalities outside the brain, and all these may affect, maybe in combination with growth hormone deficiency or other pituitary hormone deficiency, suggestive for single molecular genetics. So the last part of my talk is what are the endocrine consequences related to pituitary gland phenotype in congenital hypopit. So this guy had ectopic posterior pituitary, which is very small, and usually it is associated with extremely hypoplastic anterior pituitary and absent pituitary stalk. And this means that this is a severe condition. And this guy had large ectopic posterior pituitary, mild anterior pituitary hypoplasia, and less pituitary dysfunction. While this extra large ectopic posterior pituitary could be associated with borderline anterior pituitary and isolated GHD. And this should be recognized because neurosurgeon will be very happy to make surgery. So what about the predictive value of the pituitary stalk? This is a study that we published years ago where we defined that the gadolinium, when the gadolinium is able to identify the pituitary stalk, these patients have less severe conditions. And so the patients with undetectable pituitary stalk after gadolinium had 27 times greater risk to have multiple pituitary hormone deficiency or evolving pituitary hormone deficiency. But we are not using gadolinium anymore. So this is a paper from the Wall Street Journal showing that there is recent report exploring whether gadolinium deposits left behind in organs and tissues after MRI have harmful effect. In fact, there are deposits at the level of the CNS, And the Food and Drug Administration Advisory Committee voted to add a warning that gadolinium could be retained in certain organs. And many experts believe further research is needed, so meaning that gadolinium could be harmful. So we are not using gadolinium anymore for the diagnosis. And this paper we published last year, now we are using MRI-T2 drive, which is able to identify with 0.6 millimeter rather than 3 millimeter the pituitary stalk, as you can see from the picture. So, in terms of function, you can see that ectopic posterior pituitary, they will have the best height gain, and their height will be near the target height as compared to those who have only small pituitary or normal pituitary gland. So we have developed this table, high risk, intermediate risk, and low risk patients, where all these markers could be very helpful to make a diagnosis, to communicate a diagnosis, and to know how these patients will evolve over time. So what does the information imply for counseling? So now we know there are genetic conditions, genes implicated in growth hormone synthesis and secretions, genes implicated in cellular differentiations, genes implicated in early development, micro-rearrangement, so micro-deletions, that means that CGH array could be extremely important in the analysis, gene overlap, and pleiotropic genes implicated in different development in CNS development. And now more complex, the polygenic hypothesis and polygenic score. So that means that molecular analysis is extremely complex and the counseling is difficult. And some patients, and some with young mothers, with patients with a child with hypopit and central CNS abnormalities, we may have even an MRI in the first 25, 26 weeks of gestations, because the pituitary gland is extremely well analyzed and could be very informative as well for as in this case where the corpus callosum is absent. So we can use this for counseling as well. So patients who have ectopic posterior pituitary will have a long life growth hormone deficiency, or they will develop additional pituitary defects over time, as you may see from these papers we have published years ago in JCM, showing that they may develop ACTH deficiency or TSH deficiency over time, suggesting that the MRI phenotype is extremely important. So differences in MRI pituitary gland phenotype suggest different etiologies of hypopit and different outcomes. So patients with hypothalamic pituitary abnormalities have more severe phenotypes and are more prone to develop additional pituitary hormone defects. They have better height outcome and permanent GHD in the great majority. So this information could be available at the time of diagnosis. So MRI is useful in clinical management, guiding endocrinologists as to which patients to target for further molecular studies and counseling, whom to screen for additional hormone deficits, and who may need growth hormone replacement therapy into adult life. So thank you very much for your attention, and I would like to thank my collaborators, my many colleagues and staff nurses, geneticists, neuroradiologists, the patients and families, and of course, without the contribution of whom none of the papers could have been made possible.
Thank you. We have time for one question. Come on.
Thanks, Professor Malmi, for the interesting talk. I want to ask about the first case that you presented. The growth hormone, I think, was 10, and he didn't grow, and we diagnosed the growth hormone deficiency according to the findings in the MRI. How can we explain this lab error or this lab finding?
Yeah, I mean, you know that the hormone. Thank you very much, man. Nice to see you. I think that everyone in the audience, if you have experience with growth hormone testing, we know that growth hormone testing is not that reliable. It's not reliable in the first 6 years of life for glucagon testing because this is a powerful test, as growth hormone, as GHRH plus arginine. So we need to be careful in the interpretation of the test. So that's mean that clinical and the pictures are more reliable than the growth hormone testing. Growth hormone was higher than 10, which in second or third opinion we see a lot of these patients where pediatric endocrinologists say that it's normal. So it's not GH, it's growth hormone deficiency, it could be something else. So be careful about the interpretation.
I would like to ask you about always when we see an MRI and they say about the small pituitary layers. What do you think about this issue always about small? What do you think if it is? And then if you have to correlate with your clinical findings, if it is, then you say it is small, then it's correlated with your findings. Or just they protect themselves and they small pituitary gland.
Thank you, Ahmed. The first information, if you have a small pituitary with normal pituitary stock, and you have combined or multiple pituitary hormone deficiency, think about genetics first. If you have small pituitary and isolated growth hormone deficiency, then it may be normal variant, it may be partial anticellular, it may be the first pituitary defect in a context of pituitary of different conditions, which is very complex. So be careful about the interpretation, but isolate growth hormone deficiency with pituitary hyperplasia or small pituitary in general doesn't mean anything.
Yes.
Now, we frequently encounter the term on MRI, pituitary hyperplasia. I mean, I'm not sure what this means. It's a pathological diagnosis, but it's a big pituitary. I mean, I don't know what to do with it.
So, it's a very good question. First, if you encounter a pituitary hyperplasia, let's define it. So it's higher than 10 millimeter, usually. So we talk about this was in height, but it could be more than 5 or more than 6 because the pituitary height, because neuroradiologists they use to measure pituitary height, not the entire volume, of course. Pituitary height may be over 5 and 6 in pre-pubertal children. So you must be aware that this is not normal. If it is hyperplasia during before puberty, that this is not definitely normal. Okay, this is a mass. So sometimes it could be PROP1 defect, it could be LHX3 defect, where this is related to the genetic basis because some of these defects are related to the fact that many of the progenitors of the pituitary cells, they go into hypertrophy and there are some self-limited conditions. So you have to follow up these patients, and at puberty you have to be mainly in females rather than males, they may go over 10 millimeters. So you need to follow them. Some may have 12, some may have, but don't send them to the neurosurgeon. So be careful about this. More MRI follow-up.
I want to ask, we have to do, if we have the abnormality in the pituitary, we have to do the retesting in the growth hormone in adulthood for the children also, like the growth hormone deficiency?
I mean, we publish a lot of these studies over time, and usually you don't need to repeat MRI if you have structural pituitary abnormalities. The condition associated with the classic triad of absence of pituitary stalk, small anterior pituitary ectopic will never change over time. So sometimes you need to have a follow-up because additional CNS abnormalities are there. Just in these cases, we need a follow-up.
Any questions? Thank you very much. We are closing our sessions and
Thank you for all the speakers for this fruitful sessions. We will have a break for Friday prayer and lunch. The lunch is to the opposite to the other side. I think they will open within 10 to 15 minutes, and will please be here. There is no parallel session after that. We'll come back here at 2 o'clock sharp for the sake of time. Thank you for joining us.